Hello, everybody. I'm Marcus Plescia, the Chief Medical Officer for the Association of State and Territorial Health Officials, and I'm glad to have a little time with you today to talk a little bit about the COVID pandemic that we're in the midst of, and particularly some of the impacts it's had not only on public health, but also on cancer and cancer care. And in the course of my presentation, I'm going to start off just spending a little time talking about the course of the COVID pandemic and kind of what we've been through and where we are. I'll then segue to speak briefly about some of the impact that this has had on cancer screening and diagnosis and care and some of the concerns that that raises. And then I'll end by talking about some of the what I see the future looking like in public health as we move through the COVID pandemic and hopefully into sort of a resolution phase. And I'll talk a little bit about some things that I see happening in public health that I think may be very, very useful for the field of cancer control and hopefully provide you with some opportunities as you think about how you're going to move forward in your own communities. Before I jump into that, just a little bit about myself. I'm Marcus Plescia. I'm a family physician. I started my career in family practice, and I practiced in an academic setting for 10 years. And then I moved into a career in government public health, and I've been doing that for the last 15 years or so. I worked in the North Carolina State Public Health Department as the chronic disease director. So I oversaw all of the chronic disease programs, including the state's cancer programs. I then went to the Centers for Disease Control, where I was the director of the CDC's national cancer programs, overseeing the national screening programs and the Comprehensive Cancer Program and the National Program of Cancer Registries. I then left CDC and I went back to Charlotte, which is where I'd been in practice before, to be the local public health director there. I was the local public health director for just short of 4 years. And then I joined ASTHO. I decided to take a break from government, so I work for a professional association, but we work very, very closely with state public health departments. If I could have the next slide. This just gives you, I thought I'd talk a little bit about ASTHO. We represent state public health directors, and this is a slide that just gives you a little background on who the leaders of state public health departments are. This is a little bit old. We've got some new data right now. On this slide, about 2/3 of state public health directors actually had a medical degree. That's now bumped up to about 75% or 3/4 having a medical degree. They are in fairly powerful positions. Oftentimes they are appointed by and report directly to the governor, or if not that, they tend to report to be appointed and report directly to a cabinet member. Unfortunately, state health officials have somewhat limited tenures. You'll see from this slide that the average tenure is about 2.7 years. That's a little worse than it sounds because that takes into account various people who are in the position for a very short time, which skews this a little bit shorter. But, suffice to say, public health leaders do turn over for a variety of reasons. And we also work with the overall leadership team in state health departments. And so we get a lot of continuity through the deputies and other folks who tend to have much longer tenures. So that's who we are and what we do. And that's the perspective I'm going to come at this from. And so let me walk you through kind of what's been going on in state public health departments over the last year. If I could have the next slide. This is a slide from, right at the very beginning of the COVID-19 pandemic. And I think that this title of this article is very fitting, all hands on deck. I mean, it was all hands on deck then. Public health really rallied to pull everybody together, not just in state public health departments, but in local health departments and federally at the Centers for Disease Control. It was all hands on deck to take on this pandemic, and it has been all hands on deck really ever since. And that's one of the challenges I think we're facing when we look at things like cancer control, where we've fallen behind and I think have some serious risks. Next slide. It has not been an easy time. Everybody knows that from having experienced it yourselves. But, in addition to dealing with the COVID pandemic, many states did try, at least initially, to continue to pay attention to other major public health issues, probably the most concerning one being the opioid epidemic, which we were and still are in the middle of, and which is probably going to get much, much worse as a result of what we've been through with COVID. States were also, dealing with natural disasters that we see every year, hurricanes, heat waves, a variety of other things. They were strained. They were facing significant issues. And if I can have the next slide. And the reason they were strained is captured in these next two slides. Just in the last decade, we've seen significant reductions in, well, first of all, let me say that, for those of us who work in public health has never been anywhere near funded the level it probably needs to be funded at. But, unfortunately, in the last decade, that funding has dropped pretty considerably. And you see here 10% reduction in public health funding. And as a result, there's been a similar reduction in the public health workforce. And the next slide, I think, shows this even more dramatically. You have, really significant reductions in the number of people who are out there working in the public health workforce who were then in a position to be able to respond to this pandemic. Next slide. So, I think with that in mind, you understand a little more about why this has been such a challenging course. And I don't know why this slide has a question mark. There's no question that this has been a challenging course of the pandemic. Starting off with testing, we got off to a very bad start with testing with some of the errors made at Centers for Disease Control. But, we just never really, it took us a long time to work up any kind of testing capacity, which was so important early in the pandemic. And, that delay was amplified by the fact that we were, when it came to the materials to do testing, we were competing with the rest of the world. Add to that, we had serious problems with personal protective equipment for healthcare workers. We were running low on masks, gowns, gloves. We were feeling the strain of the workforce. We began to try to do contact tracing, which is one of the infection control mechanisms that we use in a respiratory illness like this. But we were seriously undermined by, a really modest size of the workforce. And then we had other things going on, particularly things like preparing for the influenza, which was probably a success story, and that I think we were successful through vaccination, but also because people were doing things like wearing masks in blunting that. But I think what everybody probably remembers is that while most of the public was very cooperative in the kinds of disease control initiatives we had to put forward, there were some that weren't. And one of the stories on this is a link to the Sturgis, South Dakota motorcycle rally. Some of you probably remember that. It was just a really good example of people congregating in a place and not really taking the precautions that we were asking them to. And as a result, significant increases in COVID, not just among the people who were at that rally, but because they came from far and wide, they all took it back home with them. And we saw outbreaks in a number of other states as a result of that. Next slide, please. The other real challenge that we faced is a challenge to our workforce, and particularly to our leadership. And I'm sure most of you have seen this in the news. Public health workers, and particularly public health leaders, really came under a lot of fire. Again, I think most of the public have been willing to make the changes and concessions that we've needed to control the pandemic, but there's been a small minority who have not, and they've been very vocal. And unfortunately, they've done things like harass and even threaten public health leaders. And we've probably seen turnover more at the local level, where I think it's been particularly difficult, but we've certainly seen a number of state public health directors step down, precisely because of this harassment and actually threats and having people turn up and demonstrate in your front yard. And this is really not, this is, as you can imagine, difficult for anybody, and some people just were not able to continue in that kind of an environment. Next slide, please. And so there are two things that I'm going to ask of the audience as I go through my presentation. And one is, I just want to point out, this is a movement that Johns Hopkins University put together. We'll have the link to this website available to you in the materials. And, I'd just like you all to ask you all to have a look at this. One of the things, I think the way that we counter the kinds of threats and harassment we've seen as public health leaders is by having people who are influential in communities step forward and say that's not tolerable. We will not tolerate that. And that's what the call to action is. We really need people to stand with our public health leaders. And I know many of you in the audience are clinicians, and I think having clinicians stand with our public health leaders and convey to the public that they're just doing their job is probably one of the most important things you can do, not just to show them support, but to really interrupt this cycle and move us to a better place. Next slide, please. So we then reached the turning point, I think, in the pandemic, and that is that is where we are now. It's the availability of a vaccine for COVID-19 that began to become available to the public in December. I do want to point out, I really like this slide. There's a picture, a historic picture of vaccination. And it's actually a picture that I used in my Prevent Cancer Foundation presentation that I gave 5 years ago. So I was glad to have a chance to recycle that again. But I think we all are familiar with what's going on with the vaccine. It's a turning point in that I think that we all feel a lot more hope that there's a way out of this. But I think it's also been a turning point in the public health response. This has really gone quite well. We were able to gear up quite quickly in public health systems and adapt as we understood sort of the best ways to begin to vaccinate the public. And there was a goal that we would vaccinate 1 million people a day in the first 2 months of the Biden administration, and we're vaccinating 3 million people a day. So I think the system has been very responsive, and we're getting where we need to be. Next slide. So let me segue now and talk a little bit about sort of where we are and how we go forward, and some of the things that I'm concerned about as we get back to what we might call a new normal. Now, you'll see, we'll make a link to this. This is a blog post that I wrote actually a year ago, and you're provided with a link to that as well if you'd like to have a closer look at it. A couple things on this. First of all, I think it was probably premature. I was making a call that we need to kind of adapt to a new normal and begin to address some of the other public health issues that were getting sidelined because of COVID. I suggested that a year ago. We didn't really see that happen. I think that the stress and strain and needs of COVID really continued to dominate the attention, particularly of public health leaders. But I do think we're in a place now where we're better positioned to begin to do that. But, some of the things that we raised back then is that, we need to scale up vaccination campaigns. And I'm not talking about COVID-19. I'm talking about childhood vaccinations, which fell way off during COVID. At the time that I wrote this, concerns about influenza vaccination, which actually did go fairly well. But then the big thing was concern that, we really could see a resurgence of other chronic diseases, and particularly diseases like cancer, as a result of not only the shift of attention of public health, but also the public's fear of going to medical settings, particularly early in the pandemic, and their reduced use of some of the important clinical services. In this issue of protecting the most vulnerable, I'll speak about that more in a few minutes. And then really the idea of creating a new normal. And one of the things that I'm going to return to in a few minutes towards the end of the presentation is some opportunities. And one of the opportunities is to really create a new normal about who makes up the public health workforce, and looking at some opportunities we have as a result of COVID to try to bring in more people who have direct connections with some of our more vulnerable communities and are really able to engage and work in those communities effectively. So those are some of the ideas we had for a new normal. Next slide, please. Now, one of the reasons that this is important, and here we shift a little bit to talk about cancer control, is these are slides that I got from the American Cancer Society, so I'd like to recognize them and thank them for lending these to me. But, there's been serious concerns about the effect the pandemic has had on not just overall mortality, but particularly on cancer mortality and cancer mortality going forward. And, you see here in this slide that there are really four major factors. Reduced access to care. I mean, I mentioned people were afraid, and I think we're moving beyond that now, but people have been afraid to go to the doctor because they don't want to go to a place where they could potentially be exposed to COVID. As a result, there's been delays in routine care, partly because people were afraid to go to the doctor, partly because people were just delaying things like this. This has led to later stage diagnosis, not just for screenable diseases, but for people who might be symptomatic with symptoms that would lead to a diagnosis of cancer. And then as a result of all of that, delayed and modified treatment options. Next slide, please. It's a bit of a complicated slide, so don't study it too carefully. But what's important here is these big pink downward bubbles. This looks at cancer screenings in the United States over, compared to previous years. And basically what you see here is there was a huge drop in the number of cancer screenings that occurred about 10 weeks into the year, which is around the time that the pandemic was really going, and then persisted for the period of this slide up until about 25 weeks into the pandemic, so really almost halfway through the year. And then that's when this article was written, but it does appear that, we have recovered from that now. People are returning for care and beginning to have cancer screenings, but we're running at a deficit because of this significant 15-week period where we had major reductions in breast cancer screening, colorectal cancer screening, and cervical cancer screening. Next slide, please. And so, this is concerning. Again, the overall drop in cancer diagnosis is not just because of the declines in screening, but also because of delays in diagnosis of people who are symptomatic and of those who might be detected incidentally when they're seeking care for other things. And so all of these things are contributing to concerns that, we're really about to see some significant results of the pandemic and its impact on cancer. And one more slide, please. And so I'll just close out. This is what the American Cancer Society has really tried to focus on and kind of very clearly laid out as a problem. The concern that we will see increased cancer mortality and we will see increased disparities as a result of COVID-19, and that these outcomes could be particularly devastating in years to come unless we really respond relentlessly, emphatically, and collaboratively now. So next slide, please. And so the one other thing that I wanted to touch on that I think is a real challenge for us as we go forward is the issue of health disparities. And this is a slide from fairly early in the pandemic, again, some of the media stories, but this is when we began to see this significant gap among low-income people, but particularly by race and ethnicity. People of color and people in low-income brackets were far more likely to contract COVID than the rest of the population, and they were more likely to have bad outcomes, including death. We've seen that. We started to see that early. It has persisted throughout the pandemic, and it's very, very concerning. And that's something that is clearly going to play out as far as the burden of cancer control and the burden of cancer mortality. We're going to see significant disparities here, and we're going to have to really think about how we can address them. Next slide, please. One of the thoughts was that we could begin to address this issue with the vaccination campaign for COVID-19. Once the COVID vaccine became available, one of the thoughts was that this might be a place we could start to turn around some of these disparities we're seeing. And this is a report that the National Academy of Medicine did prior to the vaccine being available, really trying to look and chart out how we could go about addressing disparity and ways that we could make the administration of the vaccine and availability of the vaccine as equitable as possible. Next slide, please. Unfortunately, so I think that previous report, if I could go back to that slide for a minute, back up one. Yeah, I think this report really had some very good recommendations. targeting specific groups, particularly essential workers, because those are groups where you do have a lot greater proportion of people of color and low-income workers, was one suggestion of a way to make the vaccine administration or availability more equitable. And then the other thing was we were very strongly urged in this report to not adopt a first-come, first-serve type approach to COVID vaccination, because that was certain to result in further disparity. When you do first come, first serve, people with means are going to do much better than the people who don't have those same means. So next slide. Unfortunately, despite all of that, this is, when we first had data come out about the vaccine administration for the first month, we already saw that we just had not been very successful in trying to make this an equitable process. And I think that has persisted, although I think we are at a point now where we may be able to address that better. And I think you all remember what happened. I mean, we did have a clear course of how to provide the vaccine in a judicious and thoughtful way. And, everybody followed that. But what we had was this kind of enormous amount of anxiety that we weren't going fast enough, and then, pleas or arguments that we needed to move away from some of the recommendations of priority groups and open things up. And what happened back in January and February is it just became kind of chaotic, and we opened things up when we didn't really have a strong supply of vaccine, and we created a system that was first come, first serve. So we're going to see inequity, particularly early in the vaccine administration, and it is what it is. And I think the thing now is to realize that and really double down on looking at ways that we can engage a much broader and more representative society into the vaccination effort. Next slide, please. Okay, so now I'd like to shift and talk a little bit about what I see as sort of the way forward. And first of all, what I'd like to say, and this is the third article that I'm citing, and again, you've been provided with links to these articles. While this was very challenging, and we certainly had a lot of missteps along the way, I think there were also great public health. There were great strengths in the public health system. The public health system did actually organize and respond quickly. We were, as I mentioned earlier, we were very short-staffed because of long-term investments. But as money became available to hire people, particularly to really scale up a contact tracing workforce, we increased the numbers of people doing that kind of work by the hundreds of thousands. So we have significantly more people, and it's an interesting workforce too, because they're not necessarily highly skilled public health workers, but what we hired for was people who had connections within their communities and who would have sort of an innate trust with other people that might really help us with things like contact tracing, getting people to stay home when they're sick and getting people to tell us who they've been in contact with so we can warn them and ask them to quarantine. Next slide, please. So going forward, there are some really positive things to build on. And one is that we now have significant funding coming into public health. And this is a slide that just shows. We started with, millions of dollars, and now we're in tens of billions of dollars being invested in public health. And you'll see on this slide that there are a range of different ways that this funding can be used. Now, I will say, running this pandemic has been expensive. And although, $10 billion, $25 billion is a lot of money. The cost of doing testing, the cost of providing vaccine to everybody for free, the cost of scaling up contact tracing workforces, those are costs that we're bearing right now. So some of this money will get used for what we're doing. But I think that there are resources now to also begin to not just build back, but expand public health. And I think the two places that we will expand is in the workforce and in our data systems. And that's where some of the opportunities may be for you and your communities to think about how you can capitalize on that for your own work in cancer prevention and control. Next slide. I just want to say briefly, looking forward, before I talk about some of the strengths and opportunities, that we have to be attentive to the things in public health that were effective during this pandemic. And the most effective thing was the opportunity to have emergency orders, emergency authorizations, things like state-issued mask mandates, things like closing down dining establishments and other places where people convene. Those were the things that got this pandemic under control. Those things are under attack in many states. Many legislatures are challenging whether public health officials and governors should have those kinds of regulatory powers. We can't fight a pandemic without those powers. In fact, we can't even put down, small community-wide outbreaks like foodborne illness outbreaks if we don't have those kinds of powers. And I said I was going to ask the audience for two things. The second thing I'm going to ask you is pay attention to this. If this is going on in your state, I really urge you to speak out that we have to continue to let public health have the tools that it needs to have to be able to react and respond quickly. Next slide, please. So the two options that I think we have in front of us, the two opportunities coming out of the pandemic, the first is workforce. And despite the difficulties that public health has faced in this pandemic, you'll see in the article here that under Stat News that driven by the pandemic and the Fauci effect, applicants flood public health schools. So that's the good thing. I think a lot of people are seeing what happened in the pandemic and seeing the work of public health, and they're attracted to this area and to the kind of work that we do and some of the values that we have in public health. And so that's a good thing. We're going to be able to draw on those people. And I think that public health, now more than ever is a very, very satisfying career choice for people who are starting out in their careers now. Next slide. And we also think that through some of the hiring and contracting that took place to build up a contact tracing workforce, we now have a workforce in public health departments or affiliated with public health departments who can do contact tracing, but who could easily be cross-trained to do any number of other things. And, just think about having somebody who's got connections and trust in communities who can go out and talk about things like cancer control and the importance of getting screenings and the importance of, seeking care if you're having certain kind of symptoms and the importance of avoiding behaviors that we know increase the risks of developing cancer, things like physical activity and various nutritional changes. And so this is the thing that I hope we can really segue to as we move forward, and we can actually expand the public health workforce with these kinds of workers who we haven't really employed as much in the past. Next slide. And this is just a little bit more on that topic. I mean, we've had ways to finance community health workers, but mostly it's been through the medical care setting, getting coverage so that they can be hired into medical care settings. But what I think some of the opportunities for federal and public funding allow is to just expand the sort of general purpose public health workforce, where we can have people who are able to go out and interface with their communities in a number of ways with a number of messages. And I think that will expand us even further than what we've been able to do with some of these more medical reimbursement type models for community health workers. So I think we're going to see real opportunities for a workforce where we have community people who are able to link in and message things with communities. And I really encourage you all to follow that and then reach out and look at ways that can help you in your own efforts in your communities to improve cancer control. Next slide. Next slide. Okay. And so this is the other thing that's going to happen. I don't want to spend a lot of time on this, but we are going to have an opportunity to really improve surveillance systems for cancer as a result of this pandemic. There's a lot of one-time funding out there. I think that funding will be used by states and locals to really expand some of their data systems. One of the best data systems out there is the National Program for Cancer Registries. And the cancer registries have done a good job at doing things like being interoperable and paying attention to data security and really having a well-trained workforce. But even cancer registries can be improved, particularly the extent to which they interoperate, the extent to which the cancer registry is accessible to other data sources, and likewise. So you get a much, those of us who practice, we don't necessarily look at just one disease alone. We look at sort of a spectrum, and what we need is our data systems to look at those spectrums too. And so there's a real opportunity for that. And I think it's still not clear exactly how that will play out, but keep an eye on that, because I think that's another way that can really enhance your practice and your opportunities in your community. And then the final slide. this is back to some messaging from the Cancer Society. I mean, we need to pivot, and I think the time to pivot is now. It is safe now for people to go back and seek medical care, and it's time for people to sort of get back to this new normal. And one of the things that we really need to encourage people is that, you know, if you've held off on getting screened, now is the time to go back. If, you know, once again, if you're having symptoms that are concerning, you know, you need to seek care and have that checked out now. And I think as we shift back to that kind of messaging and hopefully add on some improved data systems and a stronger public health workforce, together with the clinical workforce that much of you represent, I think we will have a way forward. And I think that ultimately, although we're going to feel some negative effects in cancer control from this pandemic, ultimately there's an opportunity to be stronger as well. So I hope that's been a helpful synopsis of kind of what's happened over the last year or so. You know, I think we are coming out of it now. There is a light at the end of the tunnel, and it's time to look forward and think about what the new normal looks like. And I encourage you all to be part of that and take leadership in your communities, especially so that we can make sure that this new normal puts a lot of emphasis on our efforts around cancer control. Thank you very much for your attention.
Good afternoon. Thank you so much for joining us today. I'm Erin Thomas, and just happy to be here. I have a public health background. I'm a senior program officer at the Potomac Health Foundation. We are a health conversion foundation, but in my core, I am a public health government worker. I worked at DC's health department in the Bureau of Cancer and Chronic Disease for almost 10 years. And prior to that, I worked at Fairfax County Health Department in Northern Virginia for a couple of years before kind of bouncing back. So Dr. Plescia, really thank you for your presentation. Look forward to jumping in. But before we do that, just wanted to tell you, the audience, how you can participate. So you can ask questions and or comment by clicking on the Q&A icon on the bottom right of your screen, and then questions will be moderated. We will try to get to as many of your questions as times allow. So let's get started. So Dr. Plescia, something that really resonated with me was the comment you made about community health workers and kind of bridging that trust gap, particularly during COVID, and obviously as a means to help people get back to their doctor's office and doing preventive cancer care. So what discussions do you think are going on or need to be going on at maybe the clinician level to kind of integrate those community health workers who may have been sidelined during the pandemic to kind of insert them in that process?
Yeah, well, a couple of things. I mean, first of all, I think this is a real opportunity for the cancer prevention and control workforce to really speak up. I mean, when you look at the evidence behind community health workers, a lot of it comes from cancer control. I mean, you know, patient navigators, they vary, but a lot of patient navigators, particularly around things like screening, are essentially community health workers. They're lay people who are really good at doing that kind of work. So we have a lot of experience, and we need to speak up and really push for more of that kind of component in the workforce for public health. One of the things that I really encourage people, there's a new National Association of Community Health Workers. If you're not aware of that and you're interested in community health workers and interested in supporting those efforts, check out that Community Health Worker National Association of Community Health Workers. They're doing a great job. They've got some great leadership there. I think that's a real way forward. And I think they need those of us who've worked in these settings and really understand the value of community health workers to, you know, really support and bring more credibility to what they're trying to do.
Thank you. And I also wanted to address, you talking about the underfunding of health departments pretty much across the country. And I know a lot of kind of were under fire for not, you know, being able to step in robustly related to COVID-19 and the rollout of the vaccine. I've seen that here in Northern Virginia, Prince William County, where I live, which is just south of Fairfax County. We don't have a freestanding health department. We're a district health district rather, so we have to coordinate everything through the state, which was really limited what the county could do to really reach the residents here. And the zip codes in my area were some of the highest in Virginia. So with that, could you just kind of speak to what you're seeing with the underfunding and understaffed, and a part of that, just looking at the workforce and a lot of women working in public health and leading the efforts at the health department, and just looking at kind of just how that's played out over the past year?
Sure. So it's one of these feast or famine situations. I mean, we've been underfunded for decades, and suddenly, there's so much money out there for public health. And, unfortunately, a lot of that money is one-time appropriations or resources that Congress has provided. So it's actually become quite challenging figuring out how to most effectively use those new funds. And we want to be good stewards. We don't want to just spend because the money's there. And so I went into this in the presentation a little bit. I mean, I do think there are opportunities to build the workforce back in public health, but that requires some sustained funding. So we've got to see a continued investment. It's time to fix some of these archaic public health data systems, and that can be done with one-time money. And then, there may be some opportunities for some infrastructure improvements as well. A lot of public health departments have labs that were built decades ago, and this may be a good opportunity to rebuild some of those facilities and really move into a state of the art. So those are just a few suggestions. I think the most important thing will be that the funding is sustained. Now, you also hit on another issue that came up in the chat. I mean, it is very concerning. Frankly, it was just bullying of public health professionals who were just trying to do their job. And somebody asked, isn't the workforce mostly women? And, what were you seeing with some of this kind of bullying and threats and violence? And yeah, I mean, it's hard to know. I mean, a lot of people were subject to that and didn't speak up, but I have to say, of the most publicized situations, the vast majority of them were women. And so, it was the same old thing that people think they can get away with that when it's a woman leader versus a man. And it's just that is even more concerning still. And I think when I think about the public health leaders who just got to the point where they couldn't sustain it and left their positions, many of those were. When I was doing some of this work earlier on, we got a lot of media questions about this. And National Public Radio, it appeared to be ready to do a huge expose on this, and then that never happened, and I was disappointed. I think it would have been really useful to point up that there's some sexist behavior going on here, and we really can't tolerate that, particularly in the public health workforce.
Well, Dr. Plescia, I could really talk with you about these kind of issues for pretty much all afternoon. But again, I want to thank you for your presentation as we start to wrap up. And for those that joined us this afternoon, again, thank you for taking time out of your day. So we are going to take a 2-minute break, and then we have a sponsored session from Grail about multi-cancer detection tests starting at 2:40 p.m. Eastern time. And to get to this session, you can click on the X to close this window and then go to the View Sessions tab at the top of your screen and choose Webcast 2. So again, thank you so much for joining us this afternoon.